Hi, and welcome to the Pharmacology of the Synapse. This week we will be discussing ion channels featuring anxiolytic, sedative, and hypnotic drugs. We will be discussing benzodiazepines for the use of these conditions. The learning objectives for this week are to know the clinical uses and limitations of the benzodiazepines and barbiturates, know the mechanism of action for these drugs, relate GABA A receptor structure to the pharmacology of anxiolytic and sedative drugs, and to describe the effects of benzodiazepines on GABA A receptors, synaptic transmission, and behavior. Anxiety is a very common disorder. In any given year, 19% of American adults, which is over 40 million people, suffer from an anxiety disorder. The COVID pandemic in 2020 resulted in a 25% increase in anxiety and depression worldwide. Anxiety can be normal in some situations. Symptoms include apprehension, tension, or uneasiness related to an anticipated danger or stressor, which can be normal. However, pathologic anxiety is disproportionate to the event, or it occurs without an identifiable stimulus and is accompanied by a loss of function. There are many anxiety disorders described, including those listed here, such as generalized anxiety disorder and panic and specific phobic disorders, as well as separation anxiety disorder, post-traumatic stress disorder. Anxiety is able to interrupt goal-directed activities. It causes autonomic arousal and increased vigilance, which can lead to a loss of function. For example, you can't get anything done or do anything productive in an anxiety attack. Anxiety can be characterized by the duration. So acute, which is over 2 to 3 days, short-term over 2 to 3 weeks, or chronic over several months. Treatment can include behavioral therapy and medication, such as the benzodiazepines that we will discuss later. Another condition in which the benzodiazepines are used is insomnia. Insomnia is also a very common sleep disorder, and the Mayo Clinic characterizes it as a sleep disorder that can make it hard to fall asleep, hard to stay asleep, or cause you to wake up too early and not be able to get back to sleep. You may still feel tired when you wake up. Insomnia can be primary, meaning that there's no underlying medical cause to it, or secondary due to another medical condition. 30 to 40% of Americans report symptoms of insomnia each year. The diagnosis of insomnia involves at least one of the following 4 core symptoms: difficulty initiating or maintaining sleep, sleep that is in poor quality, trouble sleeping despite ample opportunity for sleep, and waking up too early. This would be combined with at least one of the following daytime impairments related to sleep difficulties, such as problems with attention, concentration, and memory, lack of motivation, or mood disturbance or irritability. The benzodiazepines, barbiturates, and ethanol are characterized as sedative hypnotics. Now, the sedative hypnotics are very old drugs. These drugs are all CNS depressants. Thus, they are useful for anxiety and insomnia. The oldest of these drugs is alcohol, and alcoholic beverages have been used for centuries as sedatives and are still self-prescribed sedative hypnotics. In fact, drinking increased by 20 to 30% in the US during 2020 during COVID. Bromides are a class of sedative hypnotics that were discovered in the 1850s and used until the 1920s. Chloral hydrate was introduced in 1869, and the first commercial barbiturate, barbitol, was used in 1903. The first synthesized benzodiazepine was introduced in the 1960s. Benzodiazepines, barbiturates, and alcohol all produce a dose-dependent CNS depression. On this graph, you can see the level of CNS depression on the y-axis compared to the relative concentration of the drug. Note that benzodiazepines can only produce hypnosis and are thus far safer than barbiturates, which can produce respiratory depression and death at high enough concentrations. Regarding terminology, when we talk about anxiolytic doses on this graph, we mean that the dose produces a relaxation in the patient, and the patient is unconcerned with their surroundings. A sedative dose decreases activity, can moderate excitement, and calms the patient even though the patient is still awake. When we refer to hypnotic doses, we mean doses that produce drowsiness and facilitates the onset and maintenance of sleep. In medical pharmacology, hypnosis means sleep, which is distinctly different from the more pop culture definition of hypnosis, meaning suggestive states. Here we are referring to sleep. General anesthesia doses produce a state where there is a loss of consciousness from which the patient cannot be aroused. Now, the benzodiazepines cannot produce anesthesia, and their true anesthetic depth required for surgery is never achieved with these drugs alone. They also don't block the perception of pain. However, benzodiazepines are often used in conjunction with other CNS depressants for surgery, and the benzodiazepines can be used to facilitate the onset of anesthesia, but it will always require another CNS depressant. In addition to pre-anesthetic medication that we just discussed, benzodiazepines are also clinically used for anxiety and insomnia, as well as other sleep disorders. They can be used as a muscle relaxant, and some benzodiazepines can block seizures. At one point, benzodiazepines were 15% of all the prescribed drugs in the US, due to their good safety profile, their efficaciousness in these conditions, and the fact that patients request them. The side effects of benzodiazepines include anterograde amnesia, which means that people don't remember or have impaired memory when on the drugs. This might be fine for insomnia. Taking a benzodiazepine before bedtime and having impaired memory before you go to sleep may not be such a bad thing. However, anterograde amnesia can limit the use of these drugs, especially in elderly patients who already are concerned with some memory loss. Anterograde amnesia can also create the illusion of previous anesthesia. These patients don't remember that they were in pain, but they were in fact experiencing pain because benzodiazepines don't block pain perception. All benzodiazepines have anterograde amnesia to some extent, but some of them are more profound. One example is Rohypnol, which was used as a date rape drug. These drugs were slipped into people's drinks, and the victim would not remember what happened that night. Rohypnol is no longer approved in the US. Another issue with the benzodiazepines is tolerance. Tolerance becomes more pronounced at higher doses, especially when used as a long-term treatment for insomnia. There is less tolerance developed to the anxiolytic effects, which is good for the treatment of anxiety. Lastly, the benzodiazepines are Schedule IV controlled substances, so these drugs can produce physical dependence and some psychological dependence. There are many benzodiazepines on the market. I want you to know diazepam, which is going to be our prototypical benzodiazepine, which is also known as Valium. The benzodiazepines differ based on their pharmacokinetics, particularly their half-lives. The different half-lives can be matched to the type of treatment the patient needs. So a short half-life benzo would be useful for patients that can't fall asleep, for example, triazolam. And a long half-life benzo may be useful for patients with early morning awakening, such as quazepam. Diazepam has an intermediate half-life and is useful for all three conditions listed here: generalized anxiety disorder, panic and phobia disorders, as well as insomnia. The benzodiazepines have essentially replaced the earlier class of CNS depressants we discussed, the barbiturates. I had mentioned that these barbiturates can produce anesthesia and at high enough doses can cause respiratory depression and death. This chart shows some of the more well-known barbiturates. These drugs also have differences in their pharmacokinetics, including their duration of action. Thiopental has a very fast onset and is used as a general anesthetic in surgery in controlled situations. The barbiturates are generally no longer used outside of the hospital setting due to the risk of respiratory depression, and they have been essentially replaced by the benzodiazepines.